So today I'm going to talk to all of you about lung volume reduction surgery. I know that the fellows don't get a whole lot of experience seeing these patients or going over how to evaluate them, so hopefully today will be helpful. I have no disclosures. So today I'm going to try to describe the rationale for lung volume reduction surgery. We're going to work to identify patients who are appropriate for lung volume reduction surgery. And then I want you to also be able to understand the risks and the benefits of LVRS. This is just a slide that all of you know that COPD results in a huge morbidity, a huge cost, and leads to over 100,000 deaths per year. There's such substantial debility and physical impairment with this disease that I think it's obviously worthwhile to look for alternatives to medical management. As you know, what happens in emphysema is you see a loss of elasticity. And what happens is the alveoli, that are all nicely tethered in the normal lung, become destroyed, and the alveolus loses that tethering ability. So the patients can get the air in, they develop air trapping and can't get the air out. This is just another representation, kind of looking at hyperinflation. And what you can see is, in the normal patient, you have a nice coved diaphragm, and when you, at the end of expiration, it's still fairly coved. And you can see there's definitely a substantial amount of excursion that's noted. However, in patients who are hyperinflated, their diaphragms are already nearly maximally pushed down, so that when the difference between their exhalation and inspiration is greatly reduced. And therein lies the problem with emphysema, and hopefully I can show you how lung volume reduction will improve on that. So exactly what is it? What the surgeons will do is they'll go ahead and remove 20 to 30% of the lung via either a median sternotomy or a VATS. Since I've been here, I would say that over 95% of the patients who have undergone lung volume reduction, which have really, in reality, have not been that many, have all been done via VATS. The only one that I can think of that was done via sternotomy is one where they actually couldn't get in via VATS. The physiologic improvements through lung volume reduction are due to restoration of the elastic recoil of the lungs and the theory that there is improved force generating capacity of the diaphragm. So historically, back in around 1960, a surgeon by the name of Brannigan first described the use of lung volume reduction. Other surgeons, other facilities began to adopt this, but there was found to be high morbidity and mortality, and that prevented the widespread use. Then Dr. Joel Cooper in 1995, or actually in the early 1990s, started doing this again and published a contemporary case series where he did quite well. And again, there were other centers began readopting this procedure with variable results, incomplete follow-ups, and there was very little data on risk and patient selection. Due to these variable results, CMS developed a non-coverage policy for LVRS at that time. Thus came the National Emphysema Treatment Trial, which was a very unique collaboration between Center for Medicare Services and the National Heart, Lung, and Blood Institute. And what that served to do was to try to attempt to define the role of lung volume reduction in the treatment of emphysema, and then, but more importantly, to set guidelines for not just Medicare coverage, but these selection criteria that were developed back in the early 2000s, around the time of the NETT trial, are still in use today, and all the subsequent studies have adopted those selection criteria, even for bronchoscopic types of procedures. So between 1997 and 2002, there was randomization at 18 different centers. We were not one of those centers. U of M was one of those centers. And they enrolled about 1,200 patients and randomized them to 1-to-1 to medical therapy versus LVRS, which also both groups were maximally managed from a medical standpoint. So the only difference is that one group underwent surgery. So the inclusion criteria were such that the history and physical needed to be consistent with emphysema. There was bilateral emphysema on a CT scan. The patient showed evidence of hyperinflation by virtue of the TLC over 100% and the residual volume greater than or equal to 150%. The FEV1 was less than or equal to 45%. PCO2 needed to be less than 60, and PaO2 on room air greater than 45. If there were any cardiac issues, there needed to be approval by a cardiologist, and the patients all underwent completion of a 6-week program of pulmonary rehab. So there's a lot of exclusion criteria. Patients who were smoking within 6 months of randomization were excluded. If they had prior thoracic surgery, for obvious reasons, if the patient's going to undergo surgery on their chest, especially via VATS, it's a lot more difficult if there's adhesions there. If there's CT evidence of disease that's judged unsuitable for LVRS, such as bronchiectasis, if the patient is producing sputum or substantial sputum on a daily basis and is more of a chronic bronchitic as opposed to a purely emphysematous patient, then I think you're going to get yourself into trouble, because LVRS is obviously not going to change airway inflammatory issues to the degree that if somebody has chronic bronchitis, that the patient's not going to have chronic bronchitis anymore. Patients with giant bullae were excluded, and those I would define as a bullae that affects greater than or equal to about a third of the lung. Pulmonary nodules were excluded that required surgery. Nowadays, if the patient has a small pulmonary nodule and in the absence of any, say, mediastinal lymphadenopathy, and a suspicion for cancer, I think, and it's located within the area that is in question, I think that's not something that's totally exclusionary, but it was for this trial. Size matters, so if patients were obese, those patients were excluded. If the patient had significant cardiac dysrhythmias, if they had significant pulmonary hypertension, if they had diseases which would limit their survival that's completely independent of emphysema, if they had heart failure with a reduced ejection fraction, if they had very low 6-minute walks, so patients who were extremely frail, they were excluded. And if patients required too much oxygen, if they required greater than 6 liters per minute during a walk test. So this is just a lengthy a slide that kind of illustrates the characteristics of all the patients at baseline. And I just wanted to highlight that it's important to note that patients were very similar when they looked at predominantly upper lobe versus predominantly non-upper lobe emphysema. And 2/3 of the patients were predominantly upper lobe, which I always found fairly interesting, because when I see patients in the outpatient environment, I don't see 2/3 of the patients with predominantly upper lobe involvement. Which kind of brings me to the point that I think I have the biggest problem with, and I'll speak to the surgeon, I'll speak to the radiologist, is how do you quantify emphysema on CT? How do you decide that it's that the patient is upper lobe predominant? And I don't know that I have a perfect answer for that. I think centers probably who are doing more and doing it more frequently probably have a better gestalt of how heterogeneous the disease ought to be. There's a couple different ways to look at emphysema on a CT scan. And I've noticed that in the last couple years, radiology is reporting them in a different way. So in the NETT trial, the main way that they did it was they took the locations of each lung. So they took each lung, separated it into 3 segments, upper, middle, and lower, and they assigned a score, 0 to 4. So if you take 2 sides, there's 24 possible points. if there's 0, there's no emphysema. If it was 1, 1 to 25%. The next quartile was 26 to 50, then 55, 51 to 75, and then greater than that. I did find an interesting study that looked at valves, which I'm not focused on today because that's not something I do, nor are endobronchial valves or any of the other bronchoscopic therapies FDA approved in the United States. But I like this study because it came out and stated that heterogeneity is not easily defined. And in this particular study, when they were looking at their target lobes, and this was a valve study, they defined that the disease had to have a score, the target lobe had to have a score greater than 2 and had to have had to be 1 point higher than the adjacent lobes. And in this particular study, they also looked at fissures, and on CT, you needed to be able to see the majority of the interlobar fissure. And I think the significance of that is, in some of the more recent studies, they look at whether or not there's collateral, if there's collateralization, and if you can see the fissure, then that's been associated with little collateral flow, which you don't. If you're going to go ahead and put in valves and obstruct one area of the lung, if that area of the lung has substantial collateral flow, then you're not going to get significant atelectasis. Now, what we have been doing, and in addition to the other method, we also would do a density mask. And what the radiologists were doing is they were subdividing it and still using their density mask, and they were using those quartiles. Now I've noticed that they don't do that any longer, and they're reporting it more as dividing it in half, reporting it as the percent of emphysema in the upper lung zone versus the emphysema in the lower lung zone. So this is done via a densitomic analysis. It's a computer software program, and what it does, and I'll show you some samples of this, is it assigns different pixels depending on what their Hounsfield units are, and patients who have Hounsfield units of around 950, which would go along close to air, meaning if 1,000 is air, 950 would be those that are primarily emphysematous, and they are afforded a different color. And so when I show you the samples, you'll be able to see where the threshold for emphysema is located. It'll be a different color. The thing about doing a density mask is this is more likely to classify upper lobe predominant than if you just look at it with a naked eye. So I always, when I'm looking at, unless it's so frankly obvious and the patient has tons of bullous disease in the upper lobe and then nothing in the lower lobe, and they're not giant bullae, I always get a density mask. And you can order that just doing a CT emphysema protocol, and that's what they're doing. Another way to take a look at these patients, and I know some centers still do this, and use this as adjunctive data. There was a study back in 2010 and actually looked at data from the NETT trial, and they looked at, those patients also had perfusion scans done. And what they found was that when the upper lobe perfusion is less than 20%, then, and compared to the lower lobe diffusion, there was a survival advantage. So basically, it's just kind of reiterating, the more emphysema you have in the upper lobe, you would expect to find a lesser perfusion. So it kind of just corresponds to the same data. So here's an example, and it may not be the best example, but if you take a look at the upper lung zones, it certainly looks more emphysematous. You can see more lines and vessels in the lower lung zones than the upper lung zones. But it's not always easy just to look at it with the naked eye, or at least I don't find that. The density mask that was done in this patient, you can see all the red represents emphysema, and it doesn't mean that there's absolutely no emphysema in the lower lung zones, but this is definitely an example of heterogeneous disease. Here's an example of homogeneous disease, where you can see, there's certainly a lot of destruction and emphysema in the lower lung zones as well as the upper lung zones. Here's a sample of this particular patient. And whereas if you look compared to the last one, you can see there's some heterogeneity, but there's definitely a lot more emphysema compared to the initial example. And here's another one that's even worse, showing homogeneous disease. And this is one clearly that you wouldn't want to be offering lung volume reduction. There are CT findings that influence different decisions about lung volume reduction. So if there's substantial pleural disease, bronchiectasis, pulmonary hypertension, we already talked a little bit about nodules and lung cancer. 12% of the patients in the NETT trial were ineligible due to one of these findings. And it makes sense. Again, patients with bronchiectasis, removing a portion of their lung is not going to take care of their lung disease, and probably is going to make the patient worse. Pleural disease, anything that's involving the pleural is going to make it more difficult, more complicated, with higher risk to operate on that patient in the first place. So after the NETT trial was initiated, very shortly after, within months, a specific high-risk subgroup was noted. And these patients either had an FEV1 less than 20% of predicted in combination with a diffusion less than 20%, or have homogeneous emphysema on CT, or both. You can see that there is substantial increase in 30-day mortality, and the 6-month mortality was 35% in this high-risk group as compared to 5% in the medical group. So once this was noted, those patients were subsequently excluded. Just another way of illustrating the increased risk. And as you can see, in patients who have FEV1s less than 20% of predicted and homogeneous emphysema, the risk ratio for death was almost 6. So what are the causes of death and other comorbidities that occur in patients who undergo lung volume reduction? This I thought was important to note that, and it stands to reason that the majority of the complications are respiratory in nature. You can see those who underwent surgery versus those who did not undergo surgery. There's a substantial difference in those two groups. Now this is, for your boards, I think this is probably an important question if you get asked anything on the regarding lung volume reduction, is to understand which group, which quartile will benefit the most. So if you take up, they divided these patients into upper lobe, non-upper lobe predominant emphysema, and then looked at their exercise capacity. And high exercise capacity was defined on, these are all done via cardiopulmonary exercise study, and high is greater than 40 in a male, greater than 25 watts in a female, and low, less than 25 watts in a female, less than 40 watts in a male. And the group that I want you to focus on is the upper lobe predominant and low exercise capacity. In those patients, there was an improvement in all factors that were looked at in the primary outcomes. There was improvement in quality of life, there was decreased mortality, and there was an increase in exercise capacity. The other group that I think can also be included is the upper lobe predominant and high exercise capacity. And the only difference is there was no change in mortality, so there was no mortality benefit in that group. The other thing that's also really important is to look at the non-upper lobe, so homogeneous disease and high exercise capacity, and those patients actually had worsening survival. The patients with non-upper lobe or homogeneous disease and low exercise capacity, there's a suggestion that you could potentially offer this for palliative reasons, but I wouldn't personally feel comfortable, seeing the ones that I have seen, advocating for that procedure in this particular group. It's important to look at the overall mortality, and this chart excludes high-risk patients. The 30-day mortality in patients undergoing LVRS versus medical was 2% versus 0. And because I think of the high number of patients enrolled, that was statistically significant. The 3-month mortality in LVRS versus medical was 5% compared to 1.5%. And that was also statistically significant. So it's not you're not going to get your knee done. This is something I think this is not a procedure or surgery that's without risk. There's also morbidity associated with it. At 30 days, just under a third of patients were institutionalized, either in the hospital or a nursing home or a rehab. At 8 months, though, you can see that it all evens out. So this kind of is another, just I guess, a reiteration of what we've just discussed. So the NETT was divided all patients into high risk and non-high risk patients. The high risk, those with diffusion less than 20% are predicted, with homogenous disease, those patients you should not be offering lung volume reduction. The other group you should not be offering are patients with non-upper lobe predominant disease and high exercise capacity. The other three, I think you could consider it an upper lobe with low exercise. That's the best group. Those are the ones who had improvement in mortality. And you can also take a look at the upper lobe with high exercise capacity. The non-upper lobe with low exercise capacity can be done, but we have not done any of those here. So the reason I put this...
Why do they do worse, Doctor?
I'm sorry?
Why do they do worse? I know, there's those non-upper lobe predominant.
Why do they do worse?
Is there, or it's just that the study showed worse mortality?
That's what the study showed, but if you think of what's the rationale, if you have patients with upper lobe predominant disease and you're resecting 20 to 30% of the upper, the lung on both sides, you're targeting that area of worse emphysema. And what happens when you're hyperinflated and it pushes, basically can cause atelectasis of better looking lungs, lung components that are less emphysematous. So the whole reason to do it is if you resect those areas, if there's compressive atelectasis of the lower lung zones, then the idea is that that's going to expand, allow the diaphragm to come up. So if you think of the homogeneous patient and you do that, you're not necessarily, if you're homogeneous, you're not compressing the lower, the areas of the lung that are better than others. They're all equally destroyed. So to me, it seems to make sense. So I think that would be the reason.
Well, what about why is someone a low exercise capacity to better? You would think it would be the opposite.
The way I don't have
the surgery cancel out the benefit.
Well, the only way that I think of it is making sense is, so let's say you have patients who are not as physically limited by their lungs, for example. So if those patients are not as physically limited by their lungs and they have higher exercise capacity as compared to those who are low, who are primarily limited by their lungs, perhaps it would stand to reason that those patients may do better.
Because all they have is the surgery complications without much benefit since they already have high exercise capacity.
Perhaps.
Lisa, the group that lower exercise capacity, my understanding is part of the study, they were not required, like transplant, to go through rehab before the surgery, right?
Oh, no, they all went through rehab.
They all did go completed rehab. And the exercise studies were done before or after rehab?
After rehab.
Gotcha. Okay, I wanted to clarify that. Okay, thanks.
The reason I put this study up is because patients come and they think that they're going to be off their oxygen. And I thought that this was just a good illustration to show that, I can't even see oh, there it is. If you take a look they looked at rest, exertion, and sleeping and oxygen requirements after LVRS. And where the baseline, they're fairly equal. You can see, yes, some of them do do improve. Some of them, their oxygen requirements go down. But that was not an outcome that was really looked at carefully. And you can see that patients, I don't think that that's a reasonable expectation for patients. So I explained to them, there's a good chance that your oxygenation might get better, but if your only goal is to be away from this tank, then you shouldn't be doing this, because that's not a reasonable outcome or a reasonable expectation after LVRS. So this is just kind of to illustrate the outcomes, and this actually is, the first set of data came out, I think it was maybe 5 years out, and this set of data is about 5 years later. And you can see that the benefits, now this is looking at upper lobe and low exercise capacity, you can see the mortality benefits continue, even, and they don't have it beyond here because it's the years of follow-up if you're looking at all the patients. But I think it shows substantial mortality benefit even out to 7-8 years, which is, I think, a pretty good outcome. The other important data is that even out to 5 years, if you look at health-related quality of life, the upper lobe, low exercise capacity, you can see that even though health-related quality of life may dwindle, it's still substantially better than those who did not undergo LVRS. So, we're always concerned about cost, and I thought that this was interesting to look at the upper lobe, low exercise capacity, and comparing it to upper lobe and versus the non-upper lobe and low exercise capacity, and the cost per quality adjusted life year that was attributed to this. And if you look at the low exercise upper lobe emphysema, even though it's a substantial cost, if you project it out to 10 years, then it certainly reduces substantially. And projected out at 10 years, still substantial cost. But if you compare it to other types of procedures and surgeries where there's clear that are used all the time, such as CABG, you can see that the cost-adjusted quality, or the quality-adjusted life year, is very variable, and here, can actually be more than lung volume reduction. Lung transplant, obviously, for a multitude of reasons, is a costly adventure. Heart transplant, less so. But even things like a defibrillator, $47,000 per quality-adjusted life year. So I think LVRS falls within the same realm as some of the other procedures that we advocate for. Complications of LVRS, the most significant, again, are major pulmonary morbidity. These patients are prone to developing pneumonias, reintubation. Air leaks are important, although reoperation for air leak is minimal. These patients tend to have prolonged air leaks, so it's not uncommon for these patients after 7 days to still have chest tubes in and an air leak. Arrhythmias are not an uncommon complication following LVRS. Risk factors for major morbidity, cardiovascular or pulmonary, include patients who are older, which makes sense, if they're on chronic steroids, and if they have non-upper lobe predominant emphysema. I'm going to skip that. So what's happened with lung volume reduction since the NETT trial? I don't see too many. We have not done too many. I think probably in the last 2 years we've done 1, maybe 2. And I think that's not an uncommon finding. In 2004, in all centers, only 216 patients underwent lung volume reduction. And it dwindled down to 92 in 2010. So I don't know that we're that uncommon. I think there's the reasons for that, I think, are complicated, but I think that physicians have seen a large heterogeneity in response. There's also, because of that high-risk subgroup, there is a poor perception of surgical outcomes. And the data that, the outcome data from CMS are really not readily available. I thought that this study was interesting. Kind of goes over the heterogeneity when they're using the NETT criteria. And this was done at Temple University. And between 2004 and 2011, they did almost 60 patients. The interesting thing here, I think, is it's a pretty uniform group because a single surgeon performed all these surgeries. They're all done at a single center. But then if you look, and they looked at FEV1, 6-minute walk, and total watts on a cardiopulmonary exercise study done subsequent to the surgery. And you can see that there are 10 of them were improved in FEV1 only. 9 of them improved in all 3 factors. And this is what I mean by very heterogeneous results. However, their study did show, despite that heterogeneity, their survival was very comparable to the NETT. They did find also those with lower 6-minute walk distances and more emphysema, so a higher percentage of emphysema and a higher degree of hyperinflation. That group of patients in their cohort were more likely to respond. They also found that the lowest pulmonary rehab exercise capacity, so those who had really low exercise capacity, so I don't know, you're talking about 25 versus 20, but if you took their patients who had very, very low exercise capacity, that particular group seemed to have a higher risk for death. We always talk about LVRS as being a potential bridge after lung transplant, or a potential bridge to lung transplant. And this particular study in 2013 kind of highlighted some of the early and long-term postoperative outcomes. And what they did find was patients who underwent LVRS and then went on to go through lung transplant, there was a higher incidence of post-op bleeding requiring re-exploration, which makes sense. Anybody who has had prior thoracic surgery are going to be at higher risk because they're going to have adhesions. There was a higher incidence of renal insufficiency requiring hemodialysis. Not sure I can completely explain that one, other than if the patients are bleeding more, they may develop more hypotension, ATN, etc. There is an increased incidence in phrenic nerve injury, which again I think just goes along with prior surgery. And interestingly, the allograft function after 5 years in patients who underwent a lung volume reduction is less than those who didn't have lung volume reduction, although the 5-year survival was similar. So this is from the same study, and basically looked at what were the risk factors for mortality in these patients who had LVRS and then went on to have lung transplant. If they were advanced age, interesting, high LAS was not statistically significant, although an LAS greater than 50 in patients with emphysema, it's very hard to get, unless the patient's requiring an exorbitant amount of oxygen or they're actually on a ventilator. It's really hard to get emphysema patients to have an LAS greater than 50. If patients had developed pulmonary hypertension following LVRS, that was an increased risk for mortality, as was prolonged cardiopulmonary bypass time. And I think that, and transfusion requirements, forgot that one. I think prolonged cardiopulmonary bypass time, again, goes along with the fact that these patients had previous surgery. And then there are patients, when you look at their CT scans, you wind up seeing that there's heterogeneity between both sides, where one side may be quite a bit more heterogeneous than the other side. And so it makes you wonder whether or not unilateral LVRS might be useful in that particular patient population. Now, the NETT didn't do unilateral they did bilateral. And so this is not necessarily to say that unilateral is better even in this patient population, but will it work? So if maybe the patient had surgery on one side, or there were other reasons why you didn't want to touch the other side, you could consider it. And in this study, about 158 patients were looked at around the same time as the NETT trial was taking place. And for whatever reasons, and they didn't really give the reasons why unilateral was chosen, but some of these patients underwent bilateral, but it was done staged. So they did one side, got the data, and then later on went ahead and did the other side. And they actually did see improvements in quality of life, 6-minute walk, incremental treadmill test, even sustained out till 36 months. Their 5-year survival rates were pretty good. And then 5-year, in some of the patients, they did so well that they didn't even have to undergo contralateral reduction. So there are some patients, I think, you could look at that. And actually, our surgeon, Zane Hamoud, when he does it staged. He doesn't do bilateral at one time. He'll do one side, have the patient recover, and come back and do the other side. And again, this is not a talk where I'm trying to discuss different bronchoscopic treatments for emphysema, but I thought it was important to mention that there are several different types of procedures. There's endobronchial valves, plugs, blockers, airway bypass procedures, there's sealants, there's a thermal injury process that's utilized, coils. Oops. And what they attempt to do, in particular if you use endobronchial valves, is they'll go in, and the idea is to define segments of the lung where there is not collateral airflow, plug up that area, and the idea is that segment will become atelectatic, and as opposed to going in and cutting the lung out, you basically are removing the function of that portion of the lung. If that becomes atelectatic, then the lung can still expand further. And again, although this is being used in Europe and I guess Australia, none of the different bronchoscopic techniques are FDA approved, so they're not even available in the US, and I guess they're also not available in Canada, only in Europe and Australia. This is just a kind of example. I think this is one of Dr. Simoff's slides where he takes, here's your one-way valve, and plugs up, puts one, and this subsegment, this subsegment, this subsegment, to try to get the upper lobe to become atelectatic. I mean, that's the whole idea behind it. And I know that we had done some. I know some of the problems, the valves will fall out. I think overall, I think overall the patients, if you read all the studies using bronchoscopic techniques, there's definitely improvements that are seen. I think things happen a lot slower in the United States, and I think with the vent trail, I don't think that the differences between the groups was enough for the FDA to advocate for approval, and so we're kind of stuck with studies. There's still some ongoing trials. I've got a list of different trials, none of which we're actively a participant in right now. And this was just another one of Mike's slides where the goal was to place valves, and then you can see one side versus the other becoming atelectatic. In this particular patient, I guess they put valves in this region, and you can see some volume loss here. And I just, hopefully this will be something that is important in the future, but there are several valve trials still going on. Some of these are finished, others are not. There's trials all over the place. I found one of them fairly interesting, where they use biologics basically to go in and, kind of like a crazy glue, go in and just plug up airways. And I thought that was interesting. I think this trial, I believe, is still ongoing. So, just for Jessie, we saw a patient. Hang on, I want to. All right. So it's a 68-year-old lady. Her history significant for some difficulties. She's had DVTs in the past. She had a pulmonary embolism. She actually has an IVC filter, and she's got this diaphragmatic hernia. Other important things in her history were her FEV1, and that's all I had. I don't have completes. I had an FEV1, and that was it. Of nearly 900 mLs, 28% are predicted. So she falls in the realm of less than 45%. She's certainly over 20%. I don't have a diffusion. Another factor, she's still been using nicotine supplements. She last smoked 2 months ago, and I don't know, right? I don't know what's right or wrong, but I think that if one is going to go through this type of surgery, which has substantial morbidity, I think they're better off not being addicted to nicotine, so there's not a risk of going back and forth. And even with these e-cigarettes, and which is what she was using, I mean, who knows? We don't have a whole lot of data on these e-cigarettes and what inhaling these are going to do long term. So my preference, and maybe it's my bias, is that these patients ought to be off of their nicotine. So they shouldn't be addicted to nicotine. So, and then the other issue with her is her BMI was 35. So what other questions, or what do you think, what else would be important? So these are some factors that I think we both needed to look at and decide, is she or is she not a candidate? So what would you say, based on what we talked about, what would your concerns be in her?
What is her exercise tolerance?
So I don't even have a 6-minute walk yet. So, or wait, did she have a 6-minute walk? No, she didn't. I don't think we did. She also uses 3 to 4 liters of oxygen. So I don't know what her exercise tolerance is. And of course I don't have a CPX. And remember, exercise tolerance, if you really want to be pure about it and compare it to the NETT, it's done after pulmonary rehab, before surgery. So what do you guys think about this patient? Do you think she's a good candidate?
No,
You have blood gases?
Nope. I have nothing yet.
I think you need a diffusion in her is going to be a critical factor.
Yeah. If you take a look at her CT, or at her density mask, do you think she looks heterogeneous?
I don't know if you remove the area of the hernia, if that's good lung, but it doesn't look like it's very heterogeneous like the other examples that you give.
No, you're right. It's not the best example, but I'll tell you, I should have put the scores up. Her emphysema of the upper lung compared to the lower lung, it was like almost 4 to 1.
Wow.
Now, if I look at Epic, or when I'm looking at Epic, I can actually take the images. I should have done that. I should have spun it around, and you can actually see, because sometimes it's hard to look just on the frontal view. If you turn it to the side, you can often see a little bit better. But yeah, if you click on them, they'll spin. This left side, to me, looks less heterogeneous, but it's still, the ratio upper to lower lung zone was still probably more, about 2 to 1 or greater. So she's more heterogeneous on the right than she is on the left. She's obese. She has a history of PE. She's got this hernia that probably isn't helping her lung function. Fortunately, she doesn't have GI symptoms. So what would you guys want to do with the little data that I have right now? Do you feel like you can just tell her, no, you're not a candidate, or what would you want to do?
She done rehab?
Not recently.
think you need an echo with a pulmonary artery pressure too, make sure that past DVT is not causing pulmonary hypertension is half a problem.
That's what we were thinking too. And I think when you're looking at a patient for LVRS, and if you really want to make it so simple, just say, okay, is the patient's dyspnea primarily due to their emphysema? If their dyspnea is due to obesity and muscle weakness from who knows what, or pulmonary hypertension, or a multitude of other factors, then that patient's not really a pure patient, and it's going to be really hard to ascribe the outcomes of the NETT trial to that particular patient population. So I think that all those comorbid conditions have to be looked for. So yeah, these are the things that I've recommended. She obviously needs completes. We need to look at her TLC, need to look at her residual volume. I suspect she's probably going to, based on the density mass, she's probably going to have substantial elevations of her TLC and her residual volume. So
actually, with a body mass, I bet she goes the other direction. I bet she doesn't meet the criteria just because she's obese.
Maybe.
It's going to eat up her residual volume.
maybe. We'll find out.
It's going to fool you. She may have the emphysema, but the obesity is going to be masking it.
That's possible.
Yeah.
Which is why I told her she needed to lose 20 pounds.
There you go.
I wanted her to be abstinent nicotine products, and I told her we were going to be testing her. I asked her to go to pulmonary rehab. We asked them to do an echo with a right heart protocol, obviously a 6-minute walk. We need O2 dosing just to see what her requirements are. And I thought it would be important, given her history, to get a VQ scan, an ABG on room air. So most of these things are incorporated in the testing that I order for these patients. So, any questions about this particular patient?
And would she be just a good surgical candidate, technically, just with the diaphragmatic hernia?
So I didn't know about that. I thought to myself, that may be really complicated. So I called the surgeon. He says, oh yeah, we can do a twofer. Okay. So would you do this at the same time? Would you do it at a different time? And what he was indicating is he would prefer to fix the diaphragmatic hernia through a VETS before she even undergoes lung volume reduction. He thinks that fixing that would improve her respiratory status just in isolation.
Yeah, it might make her diaphragm work better too. At what
Yeah.
point would you check her watts, to categorize her?
So when I first started doing this, I was doing CPXs on all these patients. But in reality, what is that information telling me? It's telling me that, okay, if you fit into this little box, as opposed to the low exercise capacity versus high, what's the difference?
True.
There's a mortality benefit, and I felt like it wasn't giving me a whole lot of extra information. I mean, I explained to the patients, you may or may not have a mortality benefit depending on that, but I don't know that it's outside of research. I'm not sure that it's useful.
I agree, because really it doesn't change what you do, the ultimate decision.
It doesn't change their functional capacity or their quality of life.
Unless you accidentally find they have a low AT or something, but then what does that mean?
Yeah. So I stopped doing that. Any other questions based on that case?
I was wondering on the right, maybe it's graded 1:4, because as you mentioned earlier, the way they grade it is by Hounsfield, and they assign a color there, and that area that's taken up by the herniated viscera is pure white. So I was wondering if that's where the 1:4, that's why it's greater than that.
I
Or
don't
do
think
they-
so, because that would be excluded. They take the lungs out. It's not, that's below the diaphragm. Well, actually not below the diaphragm, but it's below the lung. So I don't think that should be entering into it.
Vibration.
I think you made a really important point too. I think it was your second slide. Bullous disease is different than emphysema
Yeah.
and bulectomies because, I've had every couple of years I have like a few patients that fail on most of these criteria that have bullous disease compressing something to do incredibly well after having, resection.
Yeah, I think
of
that's
the
a
tubes.
different
Totally different entity, right? I
patient
think it's important for fellows to
population.
recognize that too. Bulectomy is not the same thing as a lung volume reductions.
Right. Yeah, I think that those patients do a lot better. So in conclusion, I think hopefully I've shown you that lung volume can be an effective treatment for severe emphysema. The greatest improvements are noted in patients with upper lobe predominant disease and low oxygen or low exercise capacity. Your optimal candidate is somebody who's symptomatic in spite of optimal medical management. They meet inclusion criteria and don't have exclusion criteria as established by the NETT trial. They are agreeable to pulmonary rehab before and after, and that they understand the risks and what the anticipated benefits are. Again, sure.
Having the heterogeneous lung is the most important thing rather than the low versus high. Is there a very large reason to have to even go to pulmonary rehab in this case? The rehab, if it doesn't directly contribute to outcome, rather than just contribute to what they're...
I don't know that, I don't think I said that pulmonary rehab didn't contribute to outcome. I think
mean, the outcome of the LVRS, correct? Or is it just to give you what the low versus high is?
that was just low versus high. I don't think there's anything that says that pulmonary rehab doesn't improve a patient. I think any patient who's going to go in and have lung surgery, who has COPD or lung disease, needs to go through pulmonary rehab. They need to be stronger.
I mean, that makes sense, but is there that on that? It makes sense.
I don't.
That
The
LVRS
high-low
having
exercise
done-
capacity, that was looked at after a cardiopulmonary exercise study. And I don't know that you can translate that to patients should go through pulmonary rehab.
Because it's like pre-rehab conditioning.
No, I think that the take-home message here is certain to say, we're not going to operate on anybody who hasn't gone through pulmonary rehab.
Right.
But that's kind of the take-home message, If you
Yeah.
haven't done that, we're not going to look at you.
Question. So what, other than the echo to look at PA pressures, what do you think or you typically would do for cardiac risk assessment? Because obviously all these people have smoked and, assuming they don't have like arrhythmias that are malignant in some way, like do they all get like a stress test? Should they all be capped?
Yeah, I mean, that's a good question. And, I've talked about it with the surgeons because, all patients who are going for thoracic surgery don't all go through extensive cardiac testing. I look at their echoes. If they don't have substantial symptoms that make me think they might have angina or anything, some of them come to me already with a stress test. If I'm suspicious, I would get it, but I haven't done it in all patients. Now, whether or not that should be included in their pre-op testing may not be a bad idea, but how many times have we done stress tests? Half the time you look at stress tests and they're all negative, and they still have coronary disease. So I'm not sure. I think that I wouldn't want to discount the benefit in those who have really distinctly heterogeneous disease between the lungs, and this lady probably falls into that category. And then I think the other important things to think about is that in the future, I think that bronchoscopic methods are going to eventually be used in the U.S., but I don't know when. So I tried to ask Mike if he knew when, and he said, I have no idea. So, and that's it. Thank you.